Now, for our final presenter for the afternoon, it is Sina Yarmohammadi. I hope that I've pronounced that correctly. Beyond the bedrail and modern geriatric perspective on falls in an aged care home.
Clarifying, not the final, but the final of the long presentations. So we have a few more little ones after
perfect.
that.
Next. Okay, perfect. Thank you. My talk is not as exciting as the previous one, Helen. I've seen that machine in action is very interesting, and I must share my interest as well. I like to play with those and different things that is going on. So today I was just asked to present about the team that I lead and work with in Southwestern Sydney LHD district from Fairfield Hospital, which is a community outreach geriatric service. And I'm just going to talk about what we do and what sort of services we provide. So just the definitions, I think this has been discussed over and over today. The definition of fall: when an event that results in a person coming to rest inadvertently on the ground or on a floor or other lower level, and fall with major injuries, basically when someone has altered level of consciousness, bone fractures, or closed head injuries, and subdural hematomas, for example. I've looked at some data, Australian data from Australian Institute of Health and Welfare, very interesting website to look at. The hospitalizations 23-24, 250,000 hospitalizations were actually due to falls, and 43% of injury hospitalizations, people who had fall, just general in the community, and were injured and went into hospital and was hospitalized, 43% of those were due to falls. Again, more data, 6,700 deaths happened, which 43% of all injury deaths were due to falls. Well, the burden of fall is basically fall is leading cause of injury-related hospitalization in the elderly, and the ED trap, as we know, is the frail elderly do not do well in hospital. Hospital-acquired complications, deliriums, further falls are the risks when we transfer an elderly patient to hospital. Our mission as the co-pilot, which is the Community Older Person and Intervention and Liaison Outreach Team, which is co-pilot, which is basically the COGS service, is that we aim to prevent avoidable hospital presentations for the frail elderly. Again, more data from the AIHW. Causes of fall injuries are basically from falling on the same level. Slipping, tripping, and stumbling cause most of hospitalizations in 23-24. Falls injury by age, people age 85 and over were most likely to be injured by falls. Again, falls injury by sex, females tend to fall more. However, fall-related deaths more happen in males. Quick graph about this graph is basically represents residential aged care facilities and aged care homes, basically. And as you can see, falls, which is the purple here, and that's the percentage of residents falling in a home, ranging from 2021 to 2026 current. The range of falls almost remained the same. And falls that resulted in major injury is down here, which has declined a bit from 22 to 26, from 2.1% to 1.7%. And you can see a range of quality indicators in this graph, including pressure injuries, which we're not going to go over, and so on. And this graph basically shows most of these have actually statistically decreased in incidence from 21 to 22, including, I believe it talks about falls as well from 31, and it's basically up and down. I would just say it's very stayed similar. And this graph, again, about the quality indicators in residential aged care facilities, aged care homes, I'm sorry. Tend to not to call them facilities anymore. They are homes. And there has been a statistically significant increase in both emergency department presentations and emergency department presentations or hospital admissions. And this is where we come in. And I think the focus at the moment is just to put in more resources in the community to be able to target those people in the community, specifically in the residential aged care facilities, who are frequently are sent to hospital many times without, really engaging families or themselves due to cognitive impairment, capacity to make decisions, and so on. And our team is targeting those people to save them from a lengthy, hazardous trip to hospital. So our team, as you can see, we have geriatricians. This is a geriatrician-led team. We have a clinical nurse consultant, which holds the phone, triages referrals, which come from the aged care homes, emergency departments, inpatient teams, as well as GPs in the community. And we have a registrar. What do we do? Once we get a referral, our aim is, again, to avoid the ambulance ride to hospital while keeping patient very safe, delivering the right treatment in the right place and by the right time. So we have to be very quick, safe at the same time, and have discussions, including advanced care plan discussions, sitting of care discussions with the person themselves, and most of the times with their next of kin or substitute decision maker. And once we get involved, we get consent from the person themselves or the family or the substitute decision maker, and we start our assessment to improve our efficiency and reduce our time to review patients. Remember, these are people who are in residential aged care facilities, and we look after 16 of them. Telehealth is used broadly by our team. So straight away, we call the home, call and speak to the nurse in charge on that ward. We start a video conference. We used to use New South Wales Health PECSIP, and now we use Teams as well as Health Direct. So it's a video call. We sitting in our office with our nurse, the doctor, and the other side is the aged care home nurse, which takes the iPad or even the phone to the person who has been had a fall, and usually their ambulance have been called so far. They're either on scene or on the way. So we tend to actually intervene before that. So we look at an ambulance board. So like when you're in emergency department, you have an ambulance board that shows your arrivals, who's en route, who's waiting to get an ambulance. And we look at that and we see who's been, for example, waiting for an ambulance for the whole LHD, and we target the ones that we know that it's our aged care homes. Then we see them, we call them, and try to get a quick telehealth in while we speak to their families. So on video, most of the times it's telehealth. We do visual inspection. We do the obs, the usual. We get the vital observations. If there's a physio, sometimes there's physio on site. We ask them to stand up the patient if they're able, and then walk them, and just from a 10-minute video call, we can see if the patient is able to be ambulance, if they have severe pain in their hip, are they conscious, unconscious, and a lot of information that can be very quickly gained by us just by doing a telehealth. So once we do that, then we have an understanding if this patient really needs to go to hospital straight away. And by this time, we have not canceled any ambulance. So the ambulance call remains. And we have our initial assessment. Then we have discussions with the person and their families, next of kin, again, advanced care planning. Some of these calls, we come across homes that their protocol is just call the ambulance when someone has a fall. Because usually, as we know, GPs are not on site. The GPs usually visit once a week if they're really good. If not, usually face-to-face visit would be every second week, fortnightly, and then the rest is going to be email or calling them. So the GP is probably sitting somewhere 50 kilometers away in another nursing home or in another clinic, and they just call them and just say, "Hey, your resident has had a fall. Can you review them?" Of course, it's not. So, and the response is just sent to hospital. So a lot of the times it's been just a slip and fall on the floor, but I guess it is very hard for the care staff at the aged care home to take the responsibility, and they need support. And there's a lot of times there's no support while the person is really not injured, and many times they're actually on palliative pathway. And the advanced care plan is just to sent to hospital if symptoms are not manageable in where they live. And these are the ones that easily can be, we can engage and safely look after them for a few days in place, and we can hand over to the GPs. So once that's established, we have a chat sometimes with GPs, families, see them on video conference, and when we establish that this is a safe intervention, then we actually can organize, either we go face-to-face, we do a face-to-face review that day or the next day if it's not urgent. We can organize, either we can go face-to-face, do blood tests, put a cannula in if there's, for example, it could be anything, could be just a slip and fall and nothing, or could be a sepsis in a frail elderly patient who's not for transfer to hospital. So we go in, put a cannula in, take bloods, bring back to hospital, run all the bloods, including blood cultures and CRP, organize ECGs, organize bladder scans, a whole range of things, mobile x-rays, mobile echoes. Even if they need a CT scan done originally, then that can be done as well for us. So basically that's the assessment would be, we'll look through their medications, psychotropics, benzodiazepines, sedatives, bone protection, vitamin D, osteoporosis, cognition, if they're delirious or not, mobility, and so on. We do collaborate with inpatients, including hands and orthopedics. I've had a hand fracture, which I spoke to hands, get a CT as outpatient, and then came up with a plan, send them to ambulatory care for a full cast because the patient had advanced dementia and could not tolerate a back slap. So we just kept them in with analgesia, and then with involving the family and hands clinic and physiotherapy, we just did the casting in Fairfield Hospital Physiotherapy Department. Again, we engage GPs, paramedics. We do also engage in video conference. Sometimes they're on scene, and we do all these investigations and assessments. And we do support the residential care facilities. We talk about advanced care plan as such. And basically, summary again, it's a very important. The risk. What are the risks of this? We just want to make sure that we're not ageist. Because someone lives in a nursing home doesn't mean that they don't have the right to go to a hospital, or their family does not have the right to hospital. Many times we think clinically it's not appropriate, but if the family wants or they want, we send them to hospital because we're not there to judge them or stop that. Again, every Australian has the right to go to hospital when they would like, and if they would not accept our services. Open to questions. Thank you.
Much. Any questions? I just had one. You just touched on it there, the family. Mm-hmm. Do you find most families are happy to receive this service and not go to ED, or is it quite mixed?
Actually, it is quite mixed. We have some, it depends on their background, culture, their previous experience. Some of these frail elderly patients have had numerous admissions and presentations to hospital. So you call the family and they are so, happy that you call them and so, thank you. I want my mom to stop to go to hospital because every time they've had recurrent falls, and they're very happy for us. But there are some times that, they only think that the family may only consider a proper medical intervention as in face-to-face in ED. And those are the ones that it is very hard to, intervene. So we touch base on all. We try to intervene with the ones that is very appropriate, and those ones which do not, consider our service a proper service, then we just let slide and go in. I mean, it's not going to hurt, but yeah.
Yeah, great, thank you. Any other questions?
Are you called out more after hours and on weekends to assess a face-to-face or an outreach? Because I know staff in the care homes, they get a little bit worried about, that's why they want to call you. Course, I'm sure the responsibility is high, and the backlash can be high as well on them.
So our service is 7 days a week. Monday to Friday is 8 to 4:30. We are probably previously it was every hospital had its own outreach service in Southwestern Sydney LHD, like Liverpool, Fairfield, Campbelltown, but we have now developed a department, and I think that may also happen in North Shore. I'm not sure at this stage, but we have developed this co-pilot department that we are including all the sites, and it's going to be unified in the future. Not yet. We're developing in the middle of doing that. So 8 to 4:30, and then in the future we will have some on-call. Not at the moment, but we have nurse on-call until 8 p.m. And over the weekend, we have VMO cover from 10 a.m. to 6 to capture those. So yes, after hours is just the nurse until 8 p.m. And the nurse who's on call will just make a quick decision if they can stay safely until the next day with discussion with the family and setting expectations and setting of care. If not, they go to hospital. And over the weekend, there's a VMO, so the nurse will first will be taking the call and triaging, and then getting in. Will get the VMO involved either through phone conversations within the team or as a telehealth consultation where nurses on site and the VMO will connect. But the VMO will cover the whole LHD, so might be a busy job, but we've done that for I think 3-4 years at least. Yeah, but yeah, a lot is in hours, to be honest with you, and on the weekends we have some cover. It's not excellent, but it is something.
Sina?
Perfect. Thank you very much.